Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We've had a lot of questions relative to eye problems, eye care, and particularly retinal issues. And we have experts here. We have experts. Sitting in front of me is Dr. W. Scott Thompson. That's a wonderful moniker, W. Scott Thompson.
I'll call my mother.
Then you call Mom. And we'll blame Dad. He's an ophthalmologist, and so I should have said Dr. W. Scott Thompson. And he's a retina specialist with the Retina Group of Florida. Welcome, Doctor.
Thank you.
And a colleague of his, who is Mario Del Cid, not El Cid,
That's
Del
right.
Cid. Dr. Mario Del Cid, and he's a retina specialist and a ophthalmologist as well. Welcome, both of you. Thank you.
Yep, thank you for having us.
Good. So, tell me what the Retina Group of Florida is all about. Doctor?
I suppose since I'm the older one in the room, we began back in the 1970s as one of the first private practice retina-only groups in Florida and actually in the country. And over the years, as our ability to be able to treat retinal diseases expanded, as did we're now an 8-office group. We perform nothing but retinal procedures. So we take care of things like diabetic retinopathy, macular degeneration, some trauma, although that's a question that comes up very frequently. People think retinal detachment, they think injury. A lot of these things just have to do with the march of time as well as things that are set in place before we're born, genetics, structural development. So we basically see all of the most severe problems. And the great thing, the reason we've been able to grow steadily is that as our population has aged, our ability to deal with these diseases has dramatically changed. We can now help 90% of the people that walk through the door, whereas when I was in training 25 years ago, it was probably closer to 20%. So the technology and our knowledge has expanded drastically.
And where did you receive your training?
Well, my residency and fellowship was at the Bascom Palmer Eye Institute, University of Miami. And then I taught at Bascom before I went into private practice in 1996.
Right. Okay. Dr. El Cid,
Yes.
talk to us.
Yeah, so kind of echoing what Dr. Thompson was saying, I think one of the misconceptions that people have about eye disease is that it's normal to lose your vision, and it can be really frustrating to have a patient who had a potentially treatable or even preventable condition show up to your office months or maybe even years later with an untreatable now disease, and their misconception was that it was normal to lose vision. So I think it's really important to understand that it is normal to lose some degree of vision. For example, many people after the age of 40 or 50 start needing reading glasses, and cataracts tend to develop after a certain age, and that can affect the vision to some degree. But significant vision loss is not a normal thing to happen, and I think it's really critical that people understand that, not disseminate that kind of misconception, and also to be sure they get periodic eye exams to make sure they don't have one of these potentially treatable or preventable conditions.
Well, when you say loss of vision, tell us what are the elements that cause loss of vision?
You know, I'll be specific to retina, although there are many other conditions that can affect the eye. I mentioned cataract, and there's other things like glaucoma and such. When it comes to retina, there's probably two of the most common conditions that can cause vision loss are macular degeneration, and the other would be diabetic retinopathy. Especially here in South Florida, we see a lot of both of those things. Macular degeneration is a condition that typically affects those over the age of 65, and there's two forms of it. There's a dry form and there's a wet form. The dry form of macular, you develop these, for lack of a better phrase, spots or calcifications, although that's really not what they are, in the center of vision. And then as you develop more of these spots and they accumulate, they can start to damage the center of your vision. And I guess I should reverse a little bit and just explain what the retina is, because it's complex to understand. The eye is a very small structure, but there's a lot of components to it. I always use the analogy of a camera. The eye is literally the world's fanciest camera. And in the front of the eye, we have lenses, and the cornea, that's sort of like the lenses that you have in a camera. The retina is like the film in the camera. So for those of us that remember the days when cameras used to have film in them, the retina is like the film of the camera. And the fine focusing point of that film is the macula. So when we speak about macular issue, we're talking about an anatomic area. It's the focusing point of the retina. And so, again, going back to degeneration, the dry form causes vision loss by accumulation of these deposits, and eventually can cause atrophy or tissue loss. And the second form of macular is what we call the wet type of macular. And with wet macular, you develop these new blood vessels. These blood vessels then can ooze fluid or even bleed into the center of vision, and it can cause, unfortunately, sometimes devastating vision loss if not caught early.
So, Dr. Thompson, here we have a situation where the Retina Group of Florida specializes in retinal care and repair. Tell us what happens when a patient is remanded to your institute, because obviously people are seeking the specific talent, capability, professional techniques which are inherent within your institute. So talk to us.
Well, as Mario was just saying, the bulk of people would have trouble telling when their retina is at the root of their troubles. So most of our patients actually are referred by other eye care professionals, because so many different things can affect vision. By the time that there's actually a retinal problem diagnosed, that's when our specific talents come to bear. Although if patients call us and they believe they have a retinal problem, we're happy to check them. But basically, we're asked to weigh in both on the diagnosis of trying to find out what's wrong and also what the treatment options may be. And treatment options can vary from eye drops all the way to surgery, all the way to injection of medications into the eye, which sounds rather daunting. But truth be known, these are all fairly routine things that have, again, revolutionized what we have to offer people. So the idea that having a retinal problem is the first step down the road to losing your sight in this era is just frankly not true. And people who come to us are generally terrified because they don't know what their retina looks like. You can't look at your own eye. So just to get people to understand where they are, what their options are, that's our number one service to them. But fortunately, we have many treatments we can provide.
So do I assume that what I call the holistic ophthalmologic practice, even though they might have some involvement in retinal care, if someone wants what I would call a super subspecialist in the area of retinal care, they refer to you, correct?
Correct. An analogy would be a cardiologist. If someone has simple high blood pressure and just needs a once-a-year checkup, they wouldn't necessarily need a subspecialist. But when there's a question about diagnosis or management, that's generally when we're called upon by our colleagues. And there are very good ophthalmologists out there that are quite comfortable in monitoring, say, dry macular degeneration. But when things start to look like they're turning the wrong way, or there might have to be an intervention, that again tends to be when we're asked to weigh in.
Not to get into the almost 5-decade-old battle between ophthalmology and optometry, but the bottom line is that our School of Optometry, obviously, as you well know, coming from being trained at Bascom, we are the provider of residence in optometry to Bascom Palmer. So we have this long-standing relationship. What seems to finally come into our practice of care is the interdisciplinary relationship. The fact that I just don't do X. I do X plus Y plus Z plus A, B, C based upon my cooperative, collective knowledge with my colleagues. True?
Yeah, I would agree that it's real important to have that interdisciplinary sort of multimodal management of patients in multiple disciplines, and the eye is no different. Eye disease is complex, and both diagnostically and from a treatment standpoint, it's also become very complex. And it's difficult to now treat all of these issues alone. Oftentimes you do need to call on colleagues, and we'll do it quite frequently. We'll phone a friend and get help from other colleagues in other specialties to help us manage patients. And so I think you're right. But I also think it's important to understand, especially in our day and age, with the complexity and sort of with the ability to address some issues that many years ago we couldn't, and that we may not have the knowledge of. It's important to call on your colleagues when you need it.
That's very important. And Dr. Thompson, as the senior member here, I'm only saying to you that it's a wonderment to me that finally we've gotten to a point in time when the viewers or the patients who only want a quality of life and a care principle because they need your help. Mm-hmm. And if you lead with the philosophy that I know everything and you know nothing, it doesn't work. Because I always tell our viewers that they have to communicate with their physicians.
Oh, 100%. The patient being an active participant in their own care in any field, not just ophthalmology, is crucial. And of course, having a team where there are subspecialists, where there are a variety of levels of complexity and communication is crucial. And one of the things that we are most focused on is making sure that the people who send us their patients, they're the patients sent to us. It's not our patients, we're the consultants. We try to make sure that everyone is kept abreast of what's going on, most importantly the patient, that they understand why they're there, what their options may be. And really at the end of the day, the only thing that's important is delivering a seamless patient care experience. The nuts and bolts of who delivers what and how should be adjusted to each individual case. But at the end of the day, working in concert with optometrists, ophthalmologists, internists, endocrinologists for our diabetic patients, the new paradigm from the government is we are strongly encouraged to make sure that the primary care deliverer of care for the diabetics are kept aware of their retinal status. And this seems so simple, but this moving forward of trying to make it a one chart, one record, not little pieces broken up in different offices, hopefully we're going to continue to pursue that goal of communication.
Well, that's really very important. The whole theory of healthcare, I think, the whole presentation of healthcare is changing. We were we just did a program on neurology and neurologic surgical techniques and things of that nature. And it's amazing how, just in the condition of building a hybrid OR, where so many individuals are in there that are our colleagues with knowledge to bring a better outcome, which really leads to why people, I believe, have been so kind to witness the show and be viewers of the show, is that they want quality of life. And that's what it's all about. I mean, if more physicians would think like you're thinking, that the philosophy really is that it's not just the technique which you provide professionally, capably, but it's the idea that you link with the patient, because the patient wants one thing.
Yes.
They want quality of life.
Well, and that also speaks to the complexity of our particular little corner of the world, which is we take care of one structure within an eyeball that's only about the size of a quarter. So you can imagine the more you learn about a subject, the more you become subspecialized. You're developing knowledge and techniques that the average person wouldn't necessarily have access to, but the communication becomes a challenge because we become so fragmented within our own specialties, of making sure that at the end of the day we are coming back to each other, everyone's on the same page, And that's true in cardiology, oncology, but in retina it's a particular challenge because even people that went to excellent medical schools might have only gotten 3 or 4 weeks of ophthalmology, let alone being conversant in what we do. So to keep our colleagues abreast of what's going on, and especially the patients, is a goal we keep renewing and trying to find new and better ways. Educating the patients through forums like this, I think, is very important. And just people becoming aware that the eye, when it works properly, you don't give it a second thought. But going in and having it checked the same way you'd go to your internist once a year, finding out if you have any predisposition to any particular eye problems, getting ahead of the problem. Optometrists in particular are often the front line, the first point of contact for eye care. So invaluable resource for patients who need to watch their eye health. And as we all get older, the potential is going to be there for problems to crop up.
And not to change the subject, but to bring it to the conversation, obesity is endemic in the United States. Invariably leads to diabetes. Talk to me, Dr.
Yeah, the statistics are pretty staggering in that what the next few decades hold. I think there will be a epidemic of sorts. A large segment of the population will have diabetes. Many of them, unfortunately, go undiagnosed or take a significant amount of time to acquire the diagnosis. And by that time, a significant portion of those patients may have already developed some form of diabetic retinopathy. It's one of the leading causes of blindness here in the United States in the young, and it's very unfortunate because it's a very preventable form of eye disease as long as it's caught early and managed appropriately. And so I completely agree with you. I think there will be a significant increase in the number of patients both diagnosed with diabetes and diagnosed with diabetic eye disease. The good news is, and there is a silver lining to this, at least when it comes to diabetic retinopathy, is we have some very effective therapies for diabetic retinopathy. Many years ago, the only treatment we had was laser, and what laser did, it would essentially cauterize leaky vessels in the eye. The problem with laser, if it's done too often and too aggressively, is it actually caused some collateral damage to the retina and may have actually caused some vision loss. Now, laser is still a very appropriate therapy in a good amount of these diabetics, but now we have medications that, when placed in the eye via injection, can actually medically seal these vessels. They can eliminate blood and fluid, and in certain circumstances may reverse the disease such that they don't need any treatment. They still would need, follow-up and such. But those medicines have really revolutionized in many ways the way we manage patients with diabetic eye disease. And again, I think one of the critical components of it is catching it early and being sent appropriately and early for eye screenings are very critical.
I just want to underscore the advancement of diabetic retinopathy leads to blindness.
Yes. Oh, absolutely. Like I say, it's one of the most common causes of blindness in the young here in the United States. And as I said before, this is a young patient population that tends to get diabetes. And, unfortunately, if you're blind at a very young age, that leads to a very long period of time in which you're not going to have it's going to be very difficult to achieve many of the things that perhaps you could have achieved had you had the disease, screened and treated and prevented vision loss.
Dr. Thompson, actually a dermatologist, a well-known dermatologist, was sitting and we were talking about, all the dermatologic cancer issues. And out of nowhere, he started to talk about the most prevalent problem that he comes across, where he has to refer to an ophthalmologist, is macular degeneration. The thing that's amazing is how much macular degeneration, comes up in his practice. Not that he's examining the eyes,
Right.
but how people will say something and he immediately refers them. Talk
Well-
about the effects of sun on the retina.
Well, you've just touched on what I think is a crucial point, and that is the eyelid skin is among the thinnest and most delicate of any part of the body. So just speaking strictly to the skin cancer issue, if nothing more than that, sunglasses are a must-have in Florida. And if you have skin cancer on your eyelid, if anyone out there has had Mohs surgery, imagine taking a large section of your eyelid out, and then you have to rebuild it, and it's a very complex structure. The role of sunlight exposure for cataract and for macular degeneration still remains an object of conversation because it's probably due to multiple factors. And the people that get skin cancer, lighter colored skin, lighter colored eyes, probably are also the people at highest risk for macular degeneration. So imagine you have a magnifying glass and you're focusing all that sunlight on one spot. Well, when you're looking at something, the light is being focused right on your retina. So it just stands to reason to just unnecessarily bombard your eye with light. Nothing good can come from that. So I am a believer in sunglasses. I think it does promote better health for the inside of the eye, but definitely for the outside where the lid structures are.
Almost exactly what he said. And I remember it very clearly because every time we do talk about eye care, I bring up that subject. I just thought you would want to touch on it.
Absolutely.
Believe it or not, we're down to the last 4 minutes of the show. And I'd like you really just open it up, and we'll start with you, Dr. Cid. Cid. See, you caught me. You got me.
You caught yourself.
I caught myself. And that's what happens, you know. I mean, Charlton Heston keeps on coming out of my mind. But just give these folks an opportunity to know why they need to have their eyes checked on a, tell me how long, what it should be an annual basis or whatever, et cetera, and to beware of what could happen.
Well, as I started, I really believe eye disease, if caught early, can be treated and vision loss can be prevented. So the old misconception that vision loss is normal just doesn't stand to reason anymore. I think anybody above the age of 55 or 60 should certainly have at least a yearly eye exam. And I think questioning your family members about any history of eye disease is really important too. A lot of these things are genetically inherited. There's a predisposition, so if you have an extensive family history of some sort of eye problem, glaucoma, macular degeneration, retinal detachments, all those things increase your risk if it runs in the family. You're also someone that should have your eyes checked. And lastly, if you have symptoms, again, vision loss is not normal. So if you've lost vision, if you've noticed distortion of vision, straight lines, looking wavy, if you're struggling with something that you maybe didn't struggle with before, maybe your night driving has gotten more difficult or reading has become more difficult, and you haven't had your eyes checked in a while, go ahead and get them checked out. It could be something as simple as an update of glasses is all you need. On the other hand, you may have something more sinister developing that, again, if caught and treated early, may prevent vision loss.
Thank you. Dr. Thompson.
Well, people always ask me, what can I do to keep my eyes healthy? What can I do to avoid macular degeneration? And basically, when you go to your internist, you get the same marching orders every year. Watch your blood pressure, watch your cholesterol, don't smoke, healthy diet, low fat, moderate exercise. As it turns out, in addition to protecting your heart, that is what's going to keep your eyes healthy for the long haul. We can't run away from our genetics, but you can certainly modify risk factors. So if you're someone who has a poor diet, who smokes, who has macular degeneration, you're in for a world of trouble that can be avoided. So just like you mentioned with obesity and the host of different problems, including diabetes that come with that, we should be our own best doctors. And good common sense, conservative health care will take you far in this world. Vitamins remain somewhat controversial, but basically what's good for your heart is always going to be good for your eye.
That's interesting, because I know there are a lot of products that are suggested by eye care professionals, the lutein products and things of that nature. You're saying that it may be valuable?
Well, the information's very clear in a very specific disease, macular degeneration. We
Yes.
know from a randomized clinical trial, very well done, that it will cut the risk of visual loss. Certain vitamins called the AREDS, A-R-E-D-S study. For people who don't yet have macular degeneration, the information is far less clear whether vitamins are protective. Some people say, my mother had macular degeneration, I want to take these vitamins just in case, and I can't argue with that because there doesn't seem to be any negative impact. But we do very much recommend people with macular degeneration take advantage of the protection that the vitamins afford.
Good. Well, we're down to the last 30 seconds of the show, so it's my time to thank you very much. Both of you are from the Retina group of Florida. I know you run all the way from Pembroke Pines all the way up to the reaches of Palm Beach. So they want to reach you. I'm sure the Retina group of Florida has a telephone number, and we'll put it up. Mario Del Cid, thank you very, very much, Doctor.
Thanks again for
we
having me.
appreciate you being here.
Yep.
And Dr. W. Scott Thompson, love that. W. Scott Thompson, both of you ophthalmologists, and Dr. Thompson as a retinal specialist. We certainly appreciate your comments, because these folks really, like I said, quality of life is often brought to the task. And we appreciate you being here, and we appreciate both of your very highly skilled professional service. So thank you for being here.
Pleasure.
Folks, you asked the questions. Hopefully you got the answers. If you have any comments, you have any questions, this is a telephone number and an email address right here. Just let us know. Remember, as I always tell you, this is your show, so that's the way we get to know what you want to hear. And as I always say to yourself, take good care of yourself. Don't hold back. If you're going to go see your primary care physician, whether it's the once a year that you're seeing your ophthalmologist or optometrist, or whether it's once a year that you're seeing your internist or family doctor or whatever, or OB/GYN or whatever, you got to let them know what you're doing. You can't hold back. You got to let them know. They're not looking to do something to you that you don't want them to do. They want to help you. And remember, our healthcare system is changing. I'm not talking about the insurance part of it. I'm talking about the professional relationship. It's becoming much more interdisciplinary, and that's good for you. So what's good for you is good for me. And remember, this program comes to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.